The Active Communication Education ACE program. The ACE program is a group program for adults, usually age 50 and older, who have hearing loss or are hard of hearing, struggle to communicate in situations where they cannot hear as well, and those who want to improve their quality of life. The ACE program was developed at the University of Queensland in Brisbane, Australia, by professors Louise Hickson, Linda Worrell, and Narina Skirinsky in 2003 as both an alternative and a supplement to hearing aid fitting. The ACE program helps adults with hearing loss become more effective communicators and gives them strategies to cope with hearing loss better in their daily lives, which improves their overall social, emotional well-being. Many hard of hearing individuals struggle to hear in noisy environments even with hearing aids, and noise does not equal speech. ACE provides better communication strategies to assist with this difficulty. ACE runs for 5 weeks, 2 hours per week, and the themes of the modules are discussed. It consists of a series of modules, each addressing common difficult communication situations, such as conversations in noisy environments or group settings. In the first session, the group facilitator will help the group decide what to work on for the next 4 weeks, following a step-by-step process, and then the group works together without much input from the facilitator. Participants should attend all sessions to form bonds with each other, and this is part of what makes the program work. Families can connect and learn from each other, and hard of hearing individuals can connect their shared experiences at the end of this program. Some core components: there are no lectures, just interactive group discussions and group exercises that everyone can participate in. Some question examples are: why can't a person with hearing loss understand this situation? What's the source of the problem? What can be done to fix it? Question examples could be in regards to a difficult situation for a hard of hearing person, such as not being able to hear a family member talking in another room. Participants are supported in the groups to find solutions themselves rather than being told solutions by group facilitators. Given this example, group members would work together to find solutions, such as moving closer to the family member speaking or having both people move closer together.
So the purpose and goals of the ACE program is to help people with hearing loss improve their everyday communication skills, to teach practical strategies to make conversation easier in real-life situations, to build confidence when communicating and reduce frustration or stress during interactions. It also encourages social connection and helps reduce feelings of isolation. And then it also supports people in getting the most benefit from their hearing aids through better communication habits. So for example, Module 2 of the ACE program is conversation with background noise and background noise. So the objective of this module is to apply problem solving to the conversation and background noise, identify key skills for better communication in noise, practice how to ask for clarification, and use problem solving for a personal communication challenge. So in this module, they give out different handouts. So some of the handouts include examples of a noisy situation, conversations in background, strategies for managing background noise, clarification skills, improving communication skills of people with hearing loss. So this is an example of one of the handouts they give. It shows different places where it might be a bit noisy. For example, here the window is open and children are playing outside, or the stereo is on. In the next handout, they go over the different sources of noise and what they can do about these noises, and it really helps them kind of communicate different strategies that would help in this situation. Another example is handout 9, which is clarification skills. So over here it will show a conversation and it will X out the part that they did not hear, and then they will go over which clarification strategy they use for the X, the marked out part that they did not hear. So the clinician's role is to facilitate group sessions, introduce communication strategies and skills, teach confidence skills, encourage problem solving, provide information, create a supportive environment, monitor progress, and then show them how to implement what they have learned in the session into their daily lives.
So some challenges and considerations. So challenges are that the participants may not want to work together or resist actively participating, and ACE activities can be very time-consuming and participants can lose interest. Also, designing an effective program that targets individual challenges can be difficult. And some considerations are to design the program for a collaborative approach with clear expectations and a flexible delivery, and address communication barriers holistically with scenarios specific to the participants. Also to start active learning strategies early and promote time management for each module. So, some research and evidence on the ACE program. The effectiveness of the ACE program was evaluated through an Australian National Health and Medical Research Council grant. Ethical approval was obtained from the Behavioral and Social Sciences Ethical Review Committee at the University of Queensland. There were 178 total adult participants, and the mean age was 73.9 years, but there was a range from 53 to 94 years of age. The average hearing loss was 41.3 decibels at 0.5, 1, 2, and 4 kilohertz in the better ear. About half of the participants had been fitted with hearing aids previously. The study design was a double-blind, randomized control trial with 2 groups, and Group 1 was the placebo social program for 5 weeks, and then they completed the ACE program, and Group 2 was the ACE program only. Participants were assessed before and after the social or ACE program, and 6 months post-ACE, where 167 participants were reassessed. The assessment tools for pre- and post-program measures were the Hearing Handicap Questionnaire, the Self-Assessment of Communication, the Quantified Denver Scale of Communicative Function, the RIF Psychological Well-Being Scale, and the SF-36 Health-Related Quality of Life Measure. The results from the research showed significant improvements from pre- to post-program on the HHQ, SAC, QDS, and the Psychological Well-Being Scale, and these improvements were maintained at 6 months post-program. In an intergroup comparison, it showed a trend towards significant difference on the Hearing Handicap Questionnaire. In conclusion, ACE provides better communication strategies for adults who are hard of hearing to communicate in previously difficult communication situations. It encourages social connection and helps reduce feelings of isolation that result from a hearing loss. Research shows that ACE was very effective in improving both social communication and psychological well-being. Programs like ACE should be encouraged along with hearing aids, as hearing aids alone cannot solve a hearing loss. Hearing aids are not like glasses. ACE demonstrates that psychological well-being should be more emphasized when assessing hearing loss. These are our references. Thank you.